welcome to our podcast series, Decoding Breast Cancer. My name is Lori-Ann, and I've got Dr. Etienne, our surgeon, who is answering all the questions that we as patients are too scared to Google. We were discussing a topic on when should you have a mastectomy or when should you have breast conservation. I think for me, the mastectomy part sounds very good because as a breast cancer survivor, fear is the biggest thing for me. So for me, it was, I didn't even listen to breast conservation surgery because for me, it was just take it off because then it's never going to come back. But I think Dr. Etienne has explained that we can never with certainty say that your breast cancer will never come back. So Dr. Etienne is going to discuss and tell us more about this topic so that when we get this diagnosis, can make an informed decision that doesn't necessarily have to go into the mastectomy route. Dr. Etienne?
I normally start my conversations with patients about, do you have any preconceived expectations or do you have any ideas about what type of surgery you think we should do or that you would want to have done? Because I think it's important for me to understand the mindset of the patient that arrives. And I get a few different patients. I get a few different types of people. The one is the person that says, I've decided I am not going to Google or, whatever. I'm not going to go and do research on my own. I've decided that I've chosen a team of people that will really guide me and I'm going to listen to them and I'm going to do whatever they say. And it's not necessarily a bad thing to do. I think if you've chosen your team well and you get the feeling that these people are really pulling out all the stops to give me the best treatment, then you can do that. The next patient that I get are the ones that come in there and say, Dr. Myburg, I've always said if this happens to me, or my gynecologist said that if this happened to him or his wife or whatever, he would choose, just do a bilateral mastectomy. Even oncologists, I sometimes sit in meetings and they would use words like, well, just do a mastectomy or just quickly go and do a mastectomy. It's like painting your toenail or whatever. It's this idea that we're going to just quickly fix things and then it's going to be fine. And they don't quite understand. I always say when you're a surgeon and you take a knife and you cut someone open, and things go wrong, that's a very personal thing. It's not like someone giving you bad cancer treatment and someone dies 8 years later of the cancer and people say, oh, shame you, the cancer killed the person or the patient died of cancer. No one says, well, that doctor didn't do good treatment or didn't make a good decision in the beginning and now the cancer's come back. But when a surgeon cuts someone open and, a week later someone dies, then they say the surgeon is the one that killed the patient. So for surgeons, problems and complications is something that's really personal. So the patient that just comes in there and says, do that, obviously does not have an understanding of the implications of what they're asking or saying. But I understand that. And then I have people that have gathered information and they've had lots of different people tell them different things. So they come in with a request for something, let's say a mastectomy, but they still want to listen and hear what you have to say, the middle of the road type of people. So each of these different people have pros and cons to that scenario. I then normally ask them, would you like to have the best possible chance of cancer cure, and would you be willing to take that to walk that road, or would you prefer something else, maybe just something that's easier, something that you may feel more comfortable with, but theoretically it may not be the best cancer treatment? And almost exclusively all patients will say, I would like to have the best possible cancer treatment. I've already spoken about this whole idea of uncertainty. So how do we deal with uncertainty in life is to say, all right, let's take 10,000 women with a specific scenario, let's say a 1 centimeter breast cancer without lymph nodes, and let's split them in two groups. And for 5,000, we're going to do treatment A, and for the others, we're going to do treatment B. And then let's see at 5 and 10 and 20 years, which of those patients do the best. And do the best means have the best quality of life, live the longest period of time, does not die of breast cancer. And that, in the end, is our best way of measuring whether treatment A is better than treatment B. Remember, in 1890, we started with a radical mastectomy. Dr. Halstead came through and said, if we just make a huge, big operation and we cut as much of that patient, take the whole breast out, take the muscles out, take the lymph nodes out, take some of the ribs out, then we can actually get a step ahead of this cancer, and then we are going to cure breast cancer patients. And so for about 60 years, that was how we did things. You had a mastectomy when you had breast cancer, and slowly over time they said, well, maybe we don't have to take the ribs out. Maybe we don't have to take the muscle out. Maybe we just have to take the breast and the lymph nodes. So there were some modifications, but people just said, well, this is the operation. But the reason why people started saying, well, maybe we don't have to do that, and maybe, we can scale down on this operation, was because people were just really still doing really badly. So in spite of this massively mutilating operation, patients were just not doing well. So people were saying, well, what does it help to do these massive operations? And then there was a British surgeon with a surname of Fisher came along and said, maybe we can actually just take the tumor out and not have to do a whole mastectomy. And he did a trial where he chose half the women who had mastectomies and the other half had lumpectomies. And so, well, actually they did exactly the same. But obviously the mastectomy group had lots more complications and lots more long-term side effects. Then the era of breast conservation really came in the 1970s, and it took a long time for doctors to accept this fact that we can actually do a lot less and still have the same outcome. Now in 2022, we have the benefit that we now have follow-up data of patients that have been 20 years down the line of those trials. And we can categorically state that patients who have a small tumor, patients who would qualify for breast conservation, meaning that you've got a fairly small tumor that you can remove and still have a decent sized breast left behind. So if you have the option or the choice of having breast conservation versus a mastectomy at 20 years, the breast conservation group actually has a slightly better survival than the mastectomy group. And everybody that I say that to is like, but how's that possible? Because we did something much bigger to the cancer, and now you're telling me that those patients do worse. And the answer is yes. So again, in cancer research in general, you would often see something like theoretically adding, let's say, a treatment like metformin to breast cancer. There's molecular mechanisms that would suggest that those patients should actually do better. So we should be adding metformin, which we use for diabetes, to breast cancer women because they will survive better. But the reality is when we test that, when we say, okay, let's add this to patients and let's see then what happens, we say, oh, it actually doesn't work like that. So 8 out of every 10 molecules or things that seem to have a benefit for cancer would never even get into the clinical phase because we realize that actually either it has much worse side effects than the cancer or it just doesn't do what it's supposed to do. The cancer can get around that very efficiently. So the short answer to this is patients who have mastectomies have a bigger operation. They have much higher risk for complications. Most patients who have a mastectomy would want to have some sort of a reconstructive procedure with that, which again adds another level of complexity and possibility of risk and complications. So you're doing a bigger operation with more risk, and you're comparing it to a much smaller operation with much less risk, but that has exactly the same cancer benefit to it. So obviously if you compare those two groups, because of the more complications of the mastectomy group, you will find that those patients do a little bit worse.
So is it worse physically, not worse cancer-wise?
Worse cancer-wise and physically and body image and quality of life. Remember, your immune system plays an important role in cancer fighting. And if you're doing really big operations that last several hours, then you are knocking out your immune system for a period of time. So in theory, you could increase the chance of the cancer spreading because of doing an extended operation. We know in certain cancers that's a much more of an important thing, like colon cancer, for example. So the length of the operation plays a role in your immune system. If you have complications due to the surgery and you have to fix those complications, it may mean that your cancer treatment can't continue because you're busy fixing those complications. You can't have radiation or you can't have chemotherapy because you're dealing with complications of your wounds. So all of those little things that you increase your risk with may interfere with the way that either your body fights the cancer or we are fighting the cancer, which may have a detrimental effect on your outcome. So it may affect your cancer survival. We definitely know that patients who have mastectomies have a worse quality of life and worse body image versus those patients that have breast conservation, because we can have a much better outcome if we use your own tissue versus using foreign tissue or tissue from elsewhere in your body or a prosthesis. And then lastly, remember that in principle, breast conservation always comes with radiation to the breast. And we tend to think that radiation is just something that is a local treatment. It shouldn't really affect the rest of your body, and it should really not have an impact on whether your cancer comes back or doesn't come back. But the reality is, because of that radiation, we actually see an additional survival advantage with newer techniques. In the old days, they used to say, no, it doesn't make a difference because we would use techniques where the radiation would damage other organs. But now the radiation is so meticulously worked out and pinpoint that actually we're not damaging those other organs anymore. So now we're seeing the survival benefits for the cancer. In mastectomy patients, we would frequently not add radiation. Or not frequently, but I mean, there's a potential that we may not gain those benefits. And remember, once you've done the mastectomy, it means the breast tissue is not there anymore. So what are you irradiating? You're irradiating the muscle and the skin. And so you're irradiating chest wall. You're not irradiating breast tissue anymore. So you're dealing with different things that you are actually targeting. These are all potential reasons why we see these outcomes. In one of our previous episodes, I talked about the package. If you start watching television early, or if you're a lawyer, then it comes with a package. You don't generally have 6 children. You stay longer on things like contraceptives. So there's this sort of lifestyle package that comes. In cancer treatment, we get the same. If you choose breast conservation, it generally comes with a little package, which gives you additional benefits that you maybe won't have when you choose mastectomy. So short answer is, if you want to have the best possible chance at survival and you have a small tumor and you have the option of choosing breast conservation versus mastectomy, then choosing breast conservation is going to give you the best benefit in comparison to mastectomy.
Yeah, it makes sense. And I'm glad you can explain it to us in such a way that it gives you actually more hope, because I think we all want more hope when we find out we've got cancer or breast cancer. And also for those patients with the ductal DCIS, is that they don't have to rush off and have mastectomies, but are able to get informed decisions. And I think that's our aim with our podcast series, is if you don't have a doctor who can explain it to you in such an meticulous way, at least now you can listen to this podcast and get an informed decision, and then go to your doctor and tell him this is what you want.
The rule in my practice is no one gets an appointment that's less than an hour, because it takes time to explain all these little details. There's no way that a doctor can see you, tell you have breast cancer, discuss all the different options that you have in 15 or 30 minutes. That would be impossible. So the important thing is that you need time to explain these little details, and the concept of individualized care, meaning the treatment that we discuss for you and that we think would be most appropriate for you is not going to be the same treatment we would use for someone else. So that's really part of why we see better outcomes in high volume units, is because patients' decisions are not just a recipe that they follow. It's really pinpoint to what that patient needs. So I spend a lot of time trying to explain and educate patients so that they can make a decision that is really in their best interest. Frequently, there's more than one decision. So it's not always like either A or B. Frequently, it's A or B is a good option, C less good, and D is not a good option at all. And we would have different reasons. So I still do have the odd patient that is really anxious and wants to make this, decision for mastectomy really as an emotional, I want to almost say psychological reason. But I am also very worried that if you are the type of person that finds it difficult to trust the data, trust the research outcomes, that you would also be the type of person that would find it really difficult to deal with a wound that takes 3 months to heal, or have to walk with a flat breast for 6 months and have to have sessions of lipofilling and have follow-up operations. And so one has to think very carefully when you choose a more difficult and more risky route, whether you are willing to walk that path, because if things go wrong, you can't say, oh, let's turn back and do it the other way. Then you're in that process. And I sometimes see that patients will just get like really fed up with doctors and operations and things, and it'll almost like take a break for a year, and they'll just, walk half finished. And then they decide, okay, maybe now I feel like maybe we should finish this up again. So, and I can fully understand that. I think it's one thing if you've got a really bad cancer that fills your whole breast. I have no doubt that mastectomy is the right option. But then at least when things go wrong, we can't say, oh, well, we chose this. So I think that's the main thing for me.
Yeah, I think as a patient, we shouldn't be listening to other patients, because I think we often want to use them as reference, their good experiences and their bad experiences. So I think the best thing is to meet with your doctor and allow him to give you all the options, and then you as patient can choose the best for you with your doctor. And if you choose otherwise, then obviously, each one has his own decision that he can make. But I think for me, it is important that we as patients allow our doctors to guide us, because we aren't the doctors and we aren't the surgeons, and we haven't seen all the previous patients that's gone through a treatment. So, yeah, Dr. Etienne, thank you. I think for me, as a patient, it makes 100% sense. And I hope for the people out there that's listening to this podcast that it will also give you clarity and allow you to make an informed decision on what is the best for your outcome and for your cancer.
Excellent. Thanks, Laurie. Hopefully we'll have some interaction from our listeners. They're welcome to send us questions on our social media accounts, and we're happy to answer those if we can in future episodes. So, yeah.
Perfect. Thank you.
Bye.